Hi, welcome to NEET PG Core Revision series in Pharmacology, where I will be discussing about the important topics for the upcoming NEET PG examination. So here today we are going to talk about the antiprotozoal drugs. So let's see the first antiprotozoal drug group in which we have the antimalarial drugs. So which of the antimalarial drugs where I have the fastest action or which are the fastest acting schizonticides? So they target the RBCs there. So parasites in the RBCs. So we have here the artemisinins. Artemisinins. And out of this, artesunate, that is the fastest. Now, the only problem with this group of drugs is that they're very short acting drugs. So, because of this, there is a higher rate of recrudescence. So, they are short acting, therefore, fast recrudescence. Hence, we need to combine it with the other long acting drugs. Therefore, we go for the artemisinin combination therapy. We never give them alone. Now, moving on to the different treatment regimes for chloroquine sensitive vivax or chloroquine sensitive ovale. Remember, falciparum, we consider it as resistant to chloroquine. So, we are going to do chloroquine sensitive vivax or ovale. So, obviously, if it is chloroquine sensitive, that means you have to give chloroquine. So, what to do? The treatment, the clinical cure for the clinical cure here. Clinical cure. So, clinical cure we give chloroquine 600 milligrams, stat, this is on day 1. Then after 8 hours, you have to give another 300 milligrams. Okay, then day 2 and day 3, 300 milligram per day on both the days. So basically what you want to do is you want to give a total dose of 25 milligrams per kg. So for a 60 kg man, roughly it comes out to be around 1500 milligrams. So that's what you want to do. Now remember why we're giving 600 milligrams start and another 300 milligrams later. So we are initially giving a loading dose of chloroquine. Why are we giving a loading dose of chloroquine? Remember that chloroquine has a very, very high volume of distribution. So it gets distributed to the liver and the eye. But we want the action in the blood, in the RBCs. So that what we do, we give a loading dose so that it can actually first go saturate those sites and then it comes into the blood. Only then it can come into the blood and produce their effect. So therefore, the concept of loading dose here is because it has a very high volume of distribution. All right, so this was about the clinical cure. Okay, now it's not sufficient just to do the clinical cure, because for the complete cure in case of vivax and ovale, we also need to target the the parasite which is lying inside the liver. They're sleeping inside the liver, or that's called the hypnozoid state. So remember, this is the liver. If here, okay, let's make the liver here. So we have in the RBCs also, right? So we have the parasites and the RBCs that get taken care by the schizonticides. But in the liver, in the cells, in the liver hepatocytes, there are some dormant parasites. So they are called as hypnozoids. Now, if you don't treat these, what will happen? They will wake up, and again they will attack the RBCs, and patient will have a relapse of malaria. So for a complete cure, you have to target not only the parasites in the RBCs, but you also have to target the hypnozoid. So clinical cure, that means in the RBCs, that is done by the chloroquine. But what about the hypnozoid stage? We need another drug for this. So drug effective, and this is called as the radical cure. So radical cure is when you completely take care of this infection. So radical cure, for radical cure, what you do, you would give primaquine. So you can give primaquine 15 milligrams per day, and you need to give it for 14 days. or we have trypanosomiasis. You can give single dose of trypanosomiasis. That is also possible. So either you give primaquine or you give trypanosomiasis single dose. So both of them, they are going to target the hypnozoid stage and they bring about the radical cure. So remember, this is only for vivax and ovale. For falciparum, we don't have any hypnozoid stage. There you would not need to give it for such a long period of time for this purpose. Okay. So important here, clinical cure and radical cure. Now what is the other thing that we need to know here? For chloroquine, you need to know certain side effects. So it can cause a typical in the eye, it can cause bullseye retinopathy. Though this is more common if you use chloroquine for a prolonged period of time. So here you're not using it for a prolonged period of time. But let's say in cases of rheumatoid arthritis where you're using for a long time, there this problem is more evident. But yes, you need to know what are the issues. This bullseye retinopathy is because of chloroquine. It looks like a bullseye. Secondly, there is a tendency to cause QT prolongation. And number 3, primaquine has a maximum tendency to cause hemolysis in G6PD deficient individuals. So primaquine causes G6PD in G6PD deficient patients. It can cause hemolysis. So primaquine especially has a maximum tendency to cause this. So these are few things that you need to know. Moving on to the chloroquine resistant vivax or falciparum malaria or mixed vivax falciparum, which you also treat like chloroquine resistant malaria. So what here obviously if it is a chloroquine resistant case, chloroquine is out of question. So what is the choice? Next we have the ACT, artemisinin combination therapy. That is the treatment of choice. So ACT we are going to give. Now, how and what are we going to give here? So we are giving a combination of artesunate 50 milligrams. So 4 tabs of this. This is given for period of 3 days. Plus you give sulfadoxine and pyrimethamine combination. This is given on day 1. How much are we giving? 2 tabs, 750 and 37.5. Then we also have to give primaquine. We have to give single dose of primaquine, 2.5 milligrams, 6 tabs on day 2. Now here the role is not for radical cure. It is not given because there is no hypnozoid phase. Here the role is only that this acts as a gametocidal. Now this is the regime which is practiced in most parts of India except for the northeastern states, because in the northeastern states sulfadoxine pyrimethamine resistance is there. So this is not for northeastern states. So what will we do in case of northeastern states? We are still going to give ACT but a different combination. So here we give artemether plus lumefantrine for 3 days. Now lumefantrine is a drug whose absorption is increased if we give it along with a fatty meal. So you can give this with fatty meal to increase the absorption. Okay, so remember this, that in the chloroquine resistant vivax, falciparum malaria, mixed infections, you treat it as a resistant only, and we have the artemisinin combination therapy. So for all the parts of India except for northeastern states, this regime is followed, and this doesn't need the primaquine effect or for the radical cure. Its radical cure is only with the ACT as such, and gametocidal action because of the primaquine. And for the northeastern states, we have a different combination of ACT. All right. Moving to the severe malaria. If there is severe complicated cerebral malaria, what to do? So this is an emergency, like, so here we are going to give intravenous artemisinin. So we give intravenous artemisinin. But in people who might have some allergic reactions to this artemisinin, who are not tolerating this, we can also give quinine. Right? So the other alternative is quinine. Remember, for quinine, you give it in 5% dextrose. So give it, right? So give it with 5% dextrose to avoid hypoglycemia, because it causes hypoglycemia, to avoid hypoglycemia, right? So with 5% dextrose. All right, another important thing, what happens if there is a pregnant female who gets malaria? So malaria in pregnancy, what to do? If it is, see, the best treatment of choice or best drug of choice in pregnancy, the safest is chloroquine. So if it's a chloroquine sensitive malaria, Vivax, uncomplicated, you will definitely go with chloroquine. But remember, primaquine cannot be given. So you have to give only chloroquine, no primaquine. Why? Because primaquine causes hemolysis in G6PD deficient individuals, and the fetus is G6PD deficient. So there will be hemolysis in the fetus. Therefore, absolutely contraindicated. Now, for falciparum, which is resistant to chloroquine, what to do? You otherwise you would have given ACT, but the problem with artemisinin drugs is that they are teratogenic. So in the first trimester, we give quinine plus clindamycin, and in the second and third trimester, we can then begin with the ACT regimen. Okay. Severe complicated cerebral malaria in a pregnant female. Now, otherwise, our drug of choice is IV artesunate. What to do in this case? Here, if the mother is having complicated malaria, severe cerebral malaria, so we cannot compromise on her health. So here our mother becomes the priority and we have to save the mother. So rather than the baby, we prefer to save the mother. So here, regardless of the trimester, we will give IV artesunate. So in all trimesters. That's the guideline. All right. Now, to the other end, we move that if there is a traveler who is going to a place which is endemic for malaria, so what to do there? So for them, we need suppressive prophylaxis. Let's say it depends on what or how much time that person is going to stay there. If the stay is a longer stay, more than 6 weeks, so what to do? Then your drug becomes mefloquine, 250 milligrams once a week. Longer stay, so only once a week he needs to take a tablet. It's good for compliance also. So what and how to start? So start 2 weeks before travel. 2 weeks before travel and continue 4 weeks after coming back. Okay. Now, mefloquine has one drawback, or the ADR, that it can cause neuropsychiatric reactions. So the ADR is neuropsychiatric reactions. Therefore, it is contraindicated in cerebral malaria and even in psychosis, we can't give them. Then QT prolongation, though it has least tendency to cause QT prolongation, but we can't combine it with. So for Q, don't combine with quinine or halofentrin, because they all cause QT prolongation, right? And because of this, we need to avoid with other drugs which also causing the QT prolongation. Now, if this stay is for less than 6 weeks, shorter stay, then you can just give doxycycline, and that you need to give every day, 100 milligrams every day. So this needs to be started 2 days before travel. 2 days before travel, and same continue 4 weeks after coming back. Now, doxycycline, remember, it's a tetracycline group, so we cannot give it in cases of pregnancy, or we cannot give it in children. So it is contraindicated in pregnancy or children. Then you can give mefloquine only. So here, this you have to keep these things in mind. Now moving on to the other protozoal infections. So the first one after malaria is amoebiasis. So what is the drug of choice for intestinal amoebiasis, amoebic dysentery, or amoebic liver abscess? So these ulcers or amoebic ulcer which is formed by this, they are usually also called as flask-shaped ulcers. So this kind of ulcer they form. Flask-shaped ulcers. So the drug of choice here we have is metronidazole. What are the other uses of metronidazole? Number one, it is used for anaerobic infections. Anaerobic infections, but below the diaphragm. Below the diaphragm. So above the diaphragm we have C, below the diaphragm we have M. Clindamycin above the diaphragm, and below the diaphragm we have M. Then it is also used in case of giardiasis, trichomoniasis, number 4, it is used in bacterial vaginosis. It is used in H. pylori. Then in cases of trench mouth, gingival hyperplasia, etc. Another important thing to know that this drug can cause disulfiram like reaction with alcohol. So if a patient is on metronidazole, the patient is instructed not to consume alcohol during the treatment with metronidazole, and even 3 days after stopping the treatment with metronidazole. Moving on to the next, we have, in case it is asymptomatic and there is just luminal amoebiasis, right? So that means, so this is the intestine. Let's say this is the intestine. So the cysts, they are just in the lumen. They're not causing any symptoms. They're not invading the mucosa. So what to do here for luminal amoebiasis? The drug we have is oral paramomycin. So it's an aminoglycoside given orally because we want the local action in the intestine itself. So it is oral paramomycin. Now, moving to leishmaniasis, visceral leishmaniasis, which is also called as Kala Azar. What is the drug of choice for us? The drug of choice for us here is intravenous liposomal amphotericin B. Now, amphotericin B is a very nephrotoxic drug, lot of side effects. And what happens is, if you give it in liposomal formulation, it's a targeted delivery, there are less side effects with liposomal amphotericin B. So, it's a drug of choice, but it's a expensive drug, right? So, what does amphotericin B do? That in the cell wall, it will create holes. It combines with the ergosterol and it forms holes, and the important amino acids, etc., from the protozoa will leak out and cause the death of the protozoa. So, drug of choice is IV liposomal amphotericin B. The oral drug of choice, if you oral, is miltefosine. So, only oral drug available. Now, drug of choice for post-Kala Azar dermal leishmaniasis is again oral miltefosine. Okay. Now, moving on to the drug of choice for cutaneous leishmaniasis, which is your oriental sore. Here we use sodium stiboglucone. Drug of choice for African trypanosomiasis. So, we have recently, the treatment has evolved from the parenteral to oral therapy, which is oral fexinidazole. And for American trypanosomiasis, we have benzimidazole. Drug of choice for toxoplasmosis, we have sulfadiazine plus pyrimethamine. But remember, if in pregnancy we don't use this drug. We use spiramycin. So these are the various drugs for the protozoal infections.